As part of their 2015 state legislative program, the Alachua County Commission recently voted to support mental health funding for persons with behavioral health issues or disabilities at the state level. This includes supporting appropriate funding for core mental health and substance abuse services, supporting continuing efforts to work through Medicaid reform initiatives to ensure that persons with substance abuse and mental health treatment needs are appropriately served, supporting continuing efforts to obtain Medicaid eligibility for persons incarcerated in the county jails while waiting disposition of their cases, and supporting efforts to increase supportive housing, jail diversion, and employment and education initiatives for people with behavioral health issues and/or disabilities. No discussion about mental health would be complete without talking to my guest, Dr. Maggie Labarta. Maggie is the President and Chief Executive Officer for Meridian Behavioral Healthcare. She has been at Meridian since 1983. Prior to becoming Meridian's CEO, she directed its rural clinics, children's department, and acute care services, including the Crisis Stabilization Unit. She has also practiced as a clinical psychologist, specializing in evaluation services primarily within the family law arena, and she provided clinical and management training as well as consulting on strategic planning to a number of organizations. Maggie is involved in professional and community organizations, including the Community Foundation of North Central Florida, the North Florida Behavioral Health Network, North Florida Behavioral Health Partners, the Rural Health Partnership, the Mental Health Risk Retention Group, the Florida Council for Community Mental Health, and many others. She has been involved in local efforts related to child abuse, workforce development, homelessness, and diverting those with a mental illness from the criminal justice system. Maggie has a bachelor's degree in psychology and mathematics from Barry University and a master's and PhD in clinical and community psychology from the University of Maryland. She completed an internship in clinical and health psychology at the University of Florida J. Hillis Miller Health Center at Shands and the VA Medical Center, and also served a residency at Meridian. She has a courtesy appointment at the University of Florida in the Department of Psychiatry. Welcome, Maggie.
Thanks. It's great to be here.
So I want to get into our legislative issues that are coming up because it's a very important session this year. But before we do that, I want to talk about Meridian Behavioral Healthcare. So can you start by telling our viewers the mission of Meridian?
So Meridian's been around for 42 years. It's been the primary safety net provider of mental health and substance use disorder treatment for a 10-county area since 1972. So within that, our mission is really to promote the recovery and well-being of individuals that are affected by substance use and mental illness. And to do that, we focus on prevention, coordinated treatment, as well as supportive services.
What is the significance of having a facility like yours in the community? I mean, I know your mission is huge, and I believe you can recite all 12 counties.
I can. We cover Alachua, Dixie, Levy, Gilchrist, Hamilton, Lafayette, Suwannee, Columbia, Bradford, Baker, and Union.
Can you do that alphabetically? Or
if I had to, but I try not to. I think of them geographically, actually.
So, I mean, just in general, what is the significance of having this kind of facility here?
Well, what it means to the community is that we have a comprehensive array of services. We can do services that help people regardless of age and regardless of whether their primary issue is with substance use or a mental illness. And that's important because many of the individuals that are affected by one are also affected by the other. So it's a much more effective and efficient way to provide care. Meridian also has levels of care that we offer so that we can do everything from outreach into the community to try and identify people that need services, as well as inpatient and long-term care for those individuals. So again, it's very cost effective. It's an easier form of integrated care. So we provide enough scale that we have infrastructure to allow us to bill all third-party payers, including Medicaid and Medicare, as well as insurance. and to treat folks that are indigent and try and muster the resources that they need to get support as well.
Are you in a situation where you don't turn anyone away, or are there realities that make that impossible? Or?
The reality is that is not available to everybody. More and more our finances have been constrained. In the last several years, we have probably reduced our funding by somewhere in the order of $3 million. And obviously, when you have those kinds of reductions, services have to be reduced.
Can you give me a kind of a picture of where your funding comes from?
So our funding is largely governmental in one form or another. So about 40% of our patient population is served through Medicaid. And then another 40% through contracts that are state dollars funneled through a managing entity, which in this area is Lutheran Services Florida. So 80% is directly governmental and directly targeted at people who are at the poverty level. In addition to that, we do receive support from the counties. Alachua County, for example, provides not just support in terms of matching funds, but also invests in jail diversion services and programs that are specific to populations whose needs the county has chosen to address.
And I know your tentacles kind of reach out in so many different areas. I know you're involved with the Grace Marketplace.
We've been very much involved with Grace. We see, if you look at folks that have long-term homelessness, a very large proportion of those individuals also have a mental illness and or a substance use problem. And so to be able to be out at Grace and do some outreach efforts there has been a really, really important thing for us to support and to be a part of.
So you have a physical presence at Grace?
We do. We actually have an office and several staff people at different times doing different either housing outreach, some of our criminal justice diversion efforts that are pre-booking efforts to divert people who have a history but are not currently active in the criminal justice system. Some of those things we're doing out at Grace.
Can you give me kind of the list of services you provide? That's probably as long as your county list.
It's a really long list. So I try to focus on, so we have a crisis stabilization unit. We actually have two, one here and one in Lake City, that serves adults and children who are in the middle of an acute psychiatric episode. So they may be hallucinating, they may be suicidal. Very many of those come to us through a contact with law enforcement. Either the family has called in need of assistance or law enforcement has simply come upon them.
And how fortunate they are to go to you instead of the county jail.
And that's been a huge effort. Alachua County has been very much involved in crisis intervention training, which is a training specifically for law enforcement that really allows them to be much more effective in intervening. And they've also embraced the notion of mental health first aid, which is a less intensive course that's actually available not just to law enforcement, but to the general public to become more educated and to be better able to address a crisis in their own family or among their friends or coworkers.
I know you presented to the County Commission fairly recently, and can you just give us an idea of the magnitude or the numbers of people that you serve?
So Meridian last year touched about 20,000 people throughout our service area. In Alachua County alone, that number was probably closer to 10,000. And part of that because of our efforts at Grace and through a homeless grant for veterans and some other areas that allow us to do a lot of outreach. We have typically seen in treatment programs, so people that are actually enrolled and actively engaged in treatment, we usually see somewhere around 15,000 people a year. I'll tell you that last year, as of the end of January, we had seen 7,200 people, 2,900 of those from Alachua County. This year, we're already up to 3,100 in Alachua County.
So we hear a lot about the chart on crime going
right.
in a good way
yes.
in the state of Florida, but that's not happening in your field.
It's not happening in the mental illness field. And, we've come through a very difficult time economically, and those are the kinds of stressors that often precipitate a crisis that has a psychiatric component. And we've certainly seen our numbers in our outpatient clinics have gone up pretty dramatically. We're averaging anywhere 7 to 10% increases every year in the number of people calling us. And as you were saying a little while ago, when you have to limit the access, that gets felt in services. And so we do have wait lists for folks who need residential substance use treatment. When they need it, a bed is not always available. And likewise, we see it some with our detox services, which is really a shame, because when somebody who is in a highly addictive illness situation says, I need to change and I'm ready to make all of these really difficult steps, and you don't have the bed available, right. It's you lose an opportunity, and you can sometimes lose a life.
You know, I think it was the case last time you were on the show a few years ago, and I remember that the biggest provider of mental health services in the United States were jails.
Yes.
Is that still the case?
It is still the case. It is very much still the case in Florida. The prison system has a huge population of individuals with mental illness who are caught up in a very large population of folks who have a substance use disorder, who get caught up in the criminal justice system, and who, when they come out, have not received the level of treatment that they would have needed to receive. And one of the things that I'm proudest of is our collaboration with the county in jail diversion efforts. We have really seen that people, even people with some significant histories, can, with adequate support, wraparound services, and the cooperation of law enforcement, prosecutor, public defender, and the court, really get the support they need to turn their lives around. And it's very moving to have heard, when I was here in August presenting to the commission, 4 or 5 of the folks that had been involved in that program come up and talk about their experience and how their life is just so much better.
How does that work? So someone is arrested, and you know, I know we have our court services program that's very involved in this. You work directly to divert those people from the jail?
They're screened at the time of booking, and if that screening reveals that that person has a mental illness or may have one, then our staff work with the jail staff and the public defender and the prosecutor to screen that case to determine whether it's an appropriate case. And obviously, you know, mentally ill or not, some folks have committed a level of crime that's not going to be appropriate for release into the community. But there are a number of people, many people. We get 700 referrals a year into this program, and we typically have anywhere from 140 to 170 people actively enrolled. Once we determine that they're eligible, then our staff comes in and works with everyone to come up with an appropriate disposition. It could be mental health court. They're required to participate in treatment. They maintain a very high level of compliance. We work to release them, get them released from jail by making sure they're going to have housing and those kinds of supports. And then we really ask them to participate in therapy, case management, take medication if that's appropriate. And what we see is that in year 1, we can reduce their jail days by half and their number of arrests by half. In year 2, they've transferred out of this intensive program to routine follow-up care, and we see yet another significant drop in jail days and arrests. So the savings are in averting the kinds of costs that you would have to grow the jail, and you know that's often been a discussion at the county. Do we need to add space at the jail? So we're very proud of that. I think it's been an outstanding collaboration, and it's recognized throughout the state as one of the innovative collaborations.
In general, is it cheaper to treat people that way than it is to send them to jail?
Yeah. You know, the average cost for somebody that we see is in treatment once they're in a stable outpatient kind of mode, which is fairly rapidly, is about $2,000 a year, $3,000 a year. Last I heard, jail and prison were a little higher than that.
Yeah. I want to talk about your legislative priorities, and they're certainly in lockstep with the Alachua County Commission.
They are.
Before we get into the detail of that, though, can you give me an idea of where the state of Florida stands in terms of funding for mental health issues compared to the rest of the United States?
It's a sort of shameful place to be, actually. We're 49th in the country in funding for mental health treatment. So the per capita spending in Florida is $39.55. The median is $120.
Wow.
So not only are we 49th, but the gap between where we are in the middle is pretty substantial. And Medicaid, too, we're 43rd, so clearly we're behind there as well.
That's a good segue into, I think, what is your number one legislative priority. I know your Medicaid reimbursement rates are very low. Can you explain that?
Yeah, the Medicaid reimbursement rates were established for the most part a decade ago, and some of them are even older than that. So when you look at what medical inflation has been in this country over the last 15 years, to have rates that were set that far back means that they're covering now 60% of the cost. And so we're trying very hard to recruit staff that are qualified staff that can provide the kind of care that our patients need. And it becomes very, very difficult. In addition to that, in the last year, we've transitioned just about all of our Medicaid patients are now in managed care plans. And those plans have added a whole host of prior authorization requirements. We have actually had rates that are reduced from where we have been in the past because these managed Medicaid plans do not generally want to negotiate rates. And so we've had a rate reduction, and we've had to add administrative staff in order to be able to jump through all the hoops that were required.
Less money, more services.
Less money, less money, more administration, frankly, less clinical care.
Right. So Maggie, on this issue, what is it you're hoping the legislature will do?
So I think that the legislature, like the rest of society and healthcare, has come to a point where they recognize the importance of dealing with mental illnesses and substance use disorders. And so my hope is that they're going to do what they have done with child welfare and recognizing that part of the problem in the child welfare system was that it was underfunded. And so we are hoping to give them information that shows what the impact of these 60% of cost rates have been and are continuing to be on the system of care, and have them appropriate the funds that the Agency for Healthcare Administration that oversees Medicaid would need in order to contract at more appropriate rates.
I know one of your issues is the funding that's available through the Department of Children and Families. We've got a great chart that you provided us that we'll show right now and just give folks an idea of where that funding has gone over the years, but explain that issue to us.
Very similar. The rates were set back, some of them, frankly, when I started. You mentioned I'd been here 32 years, and in fact, some of those rates, I think, are just about that old. And so, again, it is a very difficult position to be in when you don't have the funding to cover the real cost of care. When you look at those rates adjusted for inflation, the expenditures adjusted for inflation, you see that they've actually gone down pretty significantly. And it's no surprise. Florida did not start out 49th. Just 5 or 6 years ago, we were 44th. I mean, again, not a great place to be. We were hoping for higher than that, but instead we've really fallen down.
Right. What about jail diversion? I know that's incredibly important part of what you do, and I know you're seeking additional state funding for that.
We are. There's a number of avenues in which I think that there's some opportunity. We talked a little bit earlier about the jail diversion program that we have. That's been grant funded, so every year the legislature has to appropriate those monies, and every 3 years we apply for this grant, this funding as a grant.
Where are you in that cycle now?
We are just starting our 3rd grant cycle, so we've done 6 full years and we're into our 7th year. And we've been very, very fortunate. We've got an incredibly good collaboration with the county, so our grant score is very, very high. But it's now kind of an essential community service, and so one of the things we're asking is to make those somewhat more flexible and also more permanent, so that there's some assurance that the money will be there. Another really interesting opportunity, the Florida law provides for someone who has repeated episodes of mental illness not to necessarily be committed into a hospital situation, but to allow for what's called an assisted treatment order from the court that basically says you can stay as an outpatient, you can be treated on an outpatient basis, but we're going to require you to follow that treatment plan, or you can be brought back into that inpatient setting directly. The problem is there's been no funding to support the treatment to do that. How does that affect criminal justice? Well, again, the majority of those involuntary evaluations when folks have an episode, again, is through law enforcement. They're the ones that are dealing with these individuals. So if we can have a court order that requires them to be monitored, and we have the funding to support that monitoring and treatment, we think we can take a burden off of law enforcement. So those two things, I think, have a lot of potential to be continued service to the communities.
So those three initiatives are kind of statewide.
Yes.
I know you have a local initiative that you're hoping to get through this year. Tell me about that.
One of the things we've done recently is we have an electronic health record, and it's really facilitated a world of data that we can now look at and assess. And we've always known that many of our patients, particularly those that have the more severe illnesses, have a very difficult time navigating the healthcare system, and that many of them don't have a health home. They don't have a primary care physician with whom they meet regularly. They don't get wellness visits. They don't get vaccinated. They use the emergency room, and very often that's very uncoordinated. We don't know that they've been there. So one of the things that we just recently were able to determine is that only 40% of our folks have such a relationship as we are so used to having with a primary care physician.
Right.
And at the same time, this is a population that tends to die 25 years ahead of their age mates that are not seriously ill for a lot of reasons. One is they don't access health care appropriately, but the other is that they are, sometimes by virtue of the medications they need to take, very susceptible to things like diabetes, hypertension, obesity. They smoke. They make up about 7% of the population. They smoke 44% of the cigarettes.
Is that right?
It is. It's amazing. We estimate that 75% of our seriously mentally ill patients smoke.
I did not know that.
And you see it. Our whole campus is tobacco-free in an effort to protect the health not just of our staff but our patients as well. So seeing all of this and realizing just how serious the numerical value, that 40% really shocked us. We thought it would be 60%, 70% that did have access. One of the things that we're looking is for support from the legislature for a project that would allow us to become a health home for that population that we now see who don't access care. So what that would mean is that we would be providing primary care and care coordination to those individuals, so that if they needed a specialist, we would work to get that. If they needed to have somebody remind them to get their medication for their blood pressure or their diabetes, help changing their diet and lifestyle, we could coordinate that through our own clinics. They see us as their primary health care provider. This would just allow us to expand the scope of that.
So you would add a general practitioner to your staff?
And some folks that are trained and certified in disease management and care coordination, so that we know that they are still going to need potentially specialists or a hospital stay. But we also know that for this population, and in fact for most, the leading reason for readmission is poor transition management. So by being their health home, we would be engaged from the beginning if they were admitted to the emergency room or to the hospital, and we would be helping with that transition. One of the things that happens when you have a serious mental illness is not only is your judgment impaired during episodes of the illness, but you don't interact in the same way, and you don't necessarily communicate as effectively. And so that's an area that we think we can be very helpful. We understand the deficits and the support needs that these folks have when they try to navigate the healthcare system.
Sounds like a great kind of pilot project. I'm sure the rest of the state would be very interested in the results.
Yes, and what we think is that we would be able to document, and we have an excellent relationship with UF Health, and so we would hope to be working with them to take a look at really quantifying some of the savings. Can we have these people use levels of care at the hospital less than they are now because they're getting more appropriate routine management?
Maggie, we're about at the end of our time, but tell me a little bit about the stigma of mental illness. Do you see progress in that area? What are your thoughts on how that is evolving?
I do see a lot of progress. I think there is still stigma. I think that people are still afraid of the consequences of disclosure. You see people proudly wearing their pink "I'm a cancer survivor" ribbon. You don't see too many people saying I'm a bipolar survivor, because you're still not sure how somebody's going to respond to that, particularly in employment situations. But I do think that what has grown tremendously is the understanding that these are illnesses, that they are brain disorders, and that there is really effective treatment. And so that, I think, is one of the reasons that we're able to have better conversations around funding. I think with substance use disorders, we still have a further direction that we need to take. People still tend to see this as a choice. And overcoming that hurdle of it's choice, it's behavior that you decided to engage in, is difficult. And the reality is, yes, you do have to take that first drink, smoke, hit. It's a choice. But what we also know, the science that we also know, is that the brain responds differently. And that once that brain is engaged in the way it is with addiction, and people are biologically predisposed. I mean, we all know people who drank like crazy during their college days and then went on to never do it again. But then we know others who got sucked into the vortex and couldn't get out. And I think that once that piece happens, that's where we need some understanding. We don't ask you, if you have diabetes, we don't ask you whether your diabetes was the result of your poor diet and exercise choice, or whether you're just one of those folks who's genetically predisposed.
Right.
We treat it.
Right.
We don't have that with addiction. We want to know, well, if you chose it, we are not going to treat it, and that's just wrong-headed. We now have federal law that requires parity, that requires that insurers and payers do not differentiate in how they deal with those. You can't be more restrictive in your treatment of mental illness and substance use than you are with health.
Maggie, thank you so much for the great work you do, and look forward to doing whatever we can to help in Tallahassee this year.
Well, thank you for having me, and it's always a pleasure.
We used to write letters to each other a lot. A lot of the notes, they were just really dark.
Expressions of anger. When he was mad, he hit things.
He said something to me about killing himself.
You have to take it seriously. The risk is too great.
You have to try and help them get help.
Tell somebody, tell an adult, counselor, parent, whatever.
What are you going to do? Let them destroy themselves? I don't see much of a choice at all.
Hey, how's it going? Meet my friend Lou. Lou only says something when it's very important. Right now, he's saying replace my battery. Now he's saying fire, get out of the house. Once this guy gets going, there's no shutting him up.
Smoke alarms, a sound you can live with.
At socialsecurity.gov, you can apply for retirement, disability, or Medicare from your own home.
Chekhov applied in his pajamas.